So very good afternoon, everyone. I'm presenting a rare case of Bardet Biedl Syndrome. So he was a 17-year-old male who was under regular follow-up for progressive diminution of vision due to high myopia and amblyopia with posterior staphyloma since past 2 years. His refractive error was best corrected visual acuity of 1 meter finger counting with -7 -2 cylinder for right eye and 636 in left eye, -6 with -3 cylinder at 160 degree. Now he was admitted few months back to a multi-speciality hospital with signs of acute renal failure. So this was his ophthalmic examination. The uncorrected visual acuity was a near finger counting in near right eye, 1 MFC in left eye, and the intraocular pressures were normal. Anterior segment was normal. The posterior segment showed posterior staphyloma, extensive myopic macular degeneration, and a diffuse disc pallor in both the eyes. So this is the fundus picture showing extensive myopic macular degeneration and disc pallor. This is the OCT findings showing the posterior staphyloma with macular thinning. So coming to the systemic findings, he had recently developed the acute renal failure, and he had almost all the features of the Forsyth and Beale's clinical diagnosis. Besides the cone and rod dystrophy, he had truncal obesity, there was mental retardation, there was hypogonadism with decreased testosterone levels of 55 nanogram per deciliter. There was chronic kidney disease. It was a renal parenchymal disease as diagnosed on renal biopsy. So he had all the major symptoms, major features. Only thing that was missing was polydactyly. The minor features included the secondary hyperparathyroidism with parathyroid hyperplasia, dysmorphic craniofacial features like downslanted palpable fissure, deep and widely set eyes, depressed nasal bridge, and there was a nasal speech. There was history of consanguinity. So his clinical exome analysis was done at Medigenome Narayana Nethralaya, which revealed Bardet Biedl Syndrome 16 SDCCA8. Location was autosomal recessive, exon 12. So this was the finding on genome analysis. So what was important here was, besides the routine features, although polydactyly is considered to be a primary feature of BBS, overall it has not been reported in any of the BBS 16 cases. So this was the picture. The picture was taken after the consent from the patient, having all the features described. So as discussed, all in one: cognitive impairment, dysmorphic craniofacial features, speech abnormalities, poor vision with retinal degeneration, hyperparathyroidism, obesity, CKD, and hypogonadism. So coming to the treatment, individuals with BBS required coordinated multidisciplinary care to formulate and coordinate management and therapeutic interventions. So low vision aids were suggested, counseling of the parents were done regarding the future of the child. Future need of retinal replacement therapy, as he was already in CKD, so he might be needing a dialysis or a renal transplant, or maybe somewhere in future if we have artificial kidneys. The neuropsychiatric development program for MR was suggested, vocational training was suggested, and he was started on endocrinological treatment for hypogonadism, for which he was given testosterone injections, and a treatment of hyperparathyroidism was started. So thank you so much.
Was any electrophysiological test done?
No, sir. Actually, it was not available, and initially the patient was even not ready for the exome analysis. It was only once he developed that acute renal failure that he understood the importance. So it was not done. And visual field, since the patient had a poor vision, we did not do. Yeah. Thank you.
Chaudhary.